Hello.
Hello,
Hi,
hello.
How are you doing?
doing good. How are
Good.
you?
Doing good. It's good to see both of you.
Yeah,
Good to
good.
see you.
We'll give just a minute or two here for everybody to get settled. All right, welcome in everybody. We will go ahead, wait like one more minute here. I know we've got some folks who are still joining us. I'm excited for this conversation today. I'm glad that you all could take some time out of your days to join us. All right. And it looks like we've got Katie here now. So the panel is complete. This is going to be just an awesome conversation today. So I am Jason Wood. I am the Director of Community Engagement here at ANID. And I have lived experience with an eating disorder and OCD. I ended up battling orthorexia. So when I went to the IOCDF conference this summer, I was like, oh, I'll meet a lot of other people who kind of share that intersection of orthorexia and OCD with me. I was very surprised when a lot of the people who came by our table mentioned the intersection of ARFID and OCD instead. So that was kind of the roots of this conversation and why I was really excited to be able to invite all of our friends from Compassionate Healing Institute to join us for a conversation on this today. When I first reached out to Lizette, she's like, okay, I'll check with the team to see who's interested. And I feel like we got the whole team here because everybody wants to be talking about it. So, Lizette, I'll go ahead, pass it off to you if you'd like to introduce yourself, and then I'll let the other panelists go as well.
Thanks, Jason. And I do want to say this is very much close and dear to my heart. I think uh, there is not enough talk, there's not enough understanding, and there's a lot of presentations that we see a lot of times with ARFID and OCD. So thank you for making the space for us to come and talk about this. But yeah, real quick, I'll introduce myself. So my name is Lisa Cortez. I'm a licensed psychologist and certified eating disorder specialist. My pronouns are she, her. And I'm one of the founders of Compassionate Healing Institute here in Florida, where we specialize in the treatment of OCD and eating disorder, anxiety, and related conditions.
All right. Thanks so much, Michael. Would you like to introduce yourself?
Sure. Yeah, it's nice to be with everyone today, and thanks so much for having us, Jason, and thanks to Anna as well. My name is Michael Sheffield. I'm a licensed psychologist, co-founder of Compassionate Healing Institute, where, as Dr. Cortez said, we specialize in OCD, eating disorders, anxiety disorders, and really a passion point for us is the overlap of OCD and eating disorders. So I really look forward to answering some questions and getting a chance to kind of have a really cool and robust discussion with everybody today. So
Well, thanks for being here. Looking
yeah.
forward to it. Paige, the newbie on the team. I haven't had a chance to talk with Paige before, but I'm really excited that you'll be here today. Would you like to introduce yourself?
Absolutely. Yes. I am new to Compassionate Healing Institute, but not so much new to the world of eating disorders. I am a registered dietitian licensed in the state of Florida, and I specialize in eating disorders. I've been working in this field really since I became a dietitian. So I have a lot of passion for it. I will say the world of OCD and eating disorders is also fairly new to me. I did always know that there was a correlation between the two. I've worked with clients who have experienced both. However, there's some things that I wasn't quite aware of. So I'm just really excited of the learning opportunity I've been having and just learning more about how much do they occur. So super excited to be here.
All right. Well, thanks for joining us. And last but not least, Katie, it's good to see you again. Would you like to go ahead and introduce yourself?
Sure. Thank you so much, Jason. I'm excited to be here as well. I appreciate you having us on again. So my name is Katie Jeffrey. I'm a registered dietitian nutritionist. I'm located in Connecticut. I'm licensed in a few states, Rhode Island, Florida, Connecticut, and North Carolina. And I'm really passionate about the space of both eating disorders and OCD. And I'm well versed in it. And I'm really passionate about helping individuals navigate Yep.
Thanks for being here. I forgot you were up that way. I was just out in Connecticut and Rhode Island, and it's beautiful out that way. That's the first time I've ever made it out there. So awesome. Well, thank you so much, everybody, for introducing yourselves. We'll go ahead, dive right into the conversation. We had some really good questions come in from from the people who registered. If you have additional questions for those who are attending, feel free to pop them in the chat. We'll get to what we can throughout the course of our conversation. But I guess for starters, could you just give me a brief introduction into what OCD and ARFID are, and maybe address some of the common misconceptions that are out there around both conditions?
I mean, I'd be happy to step in on the OCD part, and then if another team member wants to step in on the ARFID part, and then we can kind of connect things. So without getting too clinical, but I guess sort of sticking to some of the diagnostics around it, right? Folks with OCD typically experience unwanted thoughts, images, urges, which result in a high degree of distress, which typically lead to one of two things. Either compulsions, an action, something that they perform to alleviate the distress, or avoidance, avoiding a situation that may be triggering those things. And these things typically lead to a temporary reduction in that distress, but long-term reinforcement of the cycle. So it's a big trade-off for folks. And I think that plays in a lot on the ARFID side of things as well. So I think we'll sort of start to see sort of like the overlap here with that.
And I can chime in a little bit on the ARFID side of things. So ARFID falls under the eating disorders category, although it doesn't present like a typical eating disorder where there is like body image concerns, generally speaking. And there are three main subtypes of ARFID, one having to do with sensory sensitivities, so like texture and taste, food aversion to, certain foods that have different textures and tastes that people dislike. There's also the fear of aversive consequences. So people would restrict their food intake due to fearing something bad could happen if they eat certain things. And then there's other subtype of ARFID is the lack of interest or just like low appetite. People that just like don't find it interesting to eat or don't really feel hunger or the desire to eat. And ARFID in and of itself means avoidant restrictive food intake disorder. So it's really about like that relationship with food that's a little tricky due to these three types of categories of ARFID. At times, there is something that I think we've kind of coined as ARFID plus, even though it's not a category. If you look at it like diagnostically, it's not a category in the DSM, but when people tend to have that avoidance of food due to sensitivity, feared consequences, lack of interest, and they also have concerns with body image or fear of weight gain, we often see this like ARFID plus, kind of category. So it's something to consider too, because again, there's a significant overlap with other eating disorders in ARFID, just as much as there is when we're talking about like fears, where we often see in like OCD, as Michael was mentioning.
Awesome. Yeah, thanks for those explanations. One of the areas that we were talking about right before we started the webinar was just how oftentimes in individuals with OCD, the eating disorder is misdiagnosed as anorexia or another type of eating disorder rather than actually being recognized as ARFID. So could you talk a little bit more about maybe some of the misconceptions there that we see when it's co-occurring?
Anyone want to take this one? Okay, I guess I'll jump into. So a lot of times when there is that misconception that one could be the other, right? I mean, a lot of times we might see someone who is restricting their food and we immediately say, oh, anorexia, right? They're restricting, they probably don't want to weight gain, or they want to change their body in some sort of way. Oh, that's potentially anorexia. And then we're not getting at the core of how come they're not interested in food or avoiding food or only eating certain foods, right? It takes kind of like a deeper dive to understand what is the driving factor for some of the behaviors that we might see. So a lot of times it's tricky because people may jump real quick to a diagnosis without really looking at what's underneath or kind of like what we would name like the core fear behind some of these behaviors.
Yeah, and to just sort of add to what Lisette said, I mean, I think this is where it's really key. I'll use a big word here, more of a clinical term, but we'll kind of make it a little bit more easy. Is like doing a really good functional analysis, and what that sort of means is what's underneath the behavior, what's underneath the symptom, because a lot of times. And I'm sure, maybe a lot of the people even in this chat today can sort of relate to this. Um, Clinicians will make assumptions based on a certain behavior that the individual is engaging in, like, oh, okay, you must be struggling with your body image or a fear of weight gain and stuff like that. And these assumptions will be made really quickly. But time isn't taken to kind of ask and understand what is the function behind the behavior, because someone may be avoiding certain types of food because they're afraid they're going to choke, or they have a negative association, with that food in terms of how it feels in their body, or maybe they have a sensory sensitivity. And then on the other hand, for folks that are maybe more typically fitting into, the anorexia or bulimia categories, right? Maybe the underlying fear, right, is more so that fear of weight gain or a change in body image. And this is going to be really critical when we think about what treatment is going to best help that individual. The treatment may sort of look similar, but how we target treatment to that individual is going to be largely dependent on what's sort of underlying the reasoning behind engaging in the behaviors.
Also, while everyone was talking, I had a thought too, and it's not always so much, it's not just, confusing it with another eating disorder per se. I also often see kids maybe struggling with ARFID at a young age, and parents or providers often see it as picky eating, and so it's often overlooked. There's not much dive into of, well, why aren't they eating that meat, or why aren't they eating something of that texture or that color? It's well, they're picky, and that can go overlooked for a long period of time, where they do, as they get older, struggle with, you know, finding foods to eat, finding that desire to eat, just because it's gone untreated for so long. And I see that pretty often as well.
And Paige, to piggyback on that, I think also where people might misunderstand it, right, is that there's a significant like fear component, there's a significant like distress component. A lot of times folks we see, they want to be able to eat, or they would like to be able to go out with their friends and not worry if they're gonna have like a feared food. And instead, they might have to, they feel like they have to avoid a certain something to feel safe. So it's sometimes that part is also overlooked. It's not so much of preference or oh, they're just peculiar that way. No, there's significant fear or the stress that's going on underneath.
Yeah, and that kind of leads into one of the next areas that I wanted to talk about, and it kind of moves into the sensory and contamination aspects where we see overlap between the two. So sensory processing issues are often a key feature of ARFID. So in your experiences, are sensory sensitivities mistaken for OCD contamination or fear or vice versa?
Michael, you want to take this one? I know you work with a lot of folks like in that space.
Yeah, I can take this one. I think once again, it goes back to that same question of, a good functional analysis and like what's underlying the behavior. So I work with a lot of autistic individuals who have, either hypersensitivity, like an increased sensitivity to things, or in some case hyposensitivity, right, where they're not as sensitive to other things, right? So the wiring in the brain is actually a bit different. Um, so in that sense, we really sort of want to understand, like, these are complex things, and I think we try to fit things nice and neat into sort of like boxes, and that's sort of what the DSM does. And as we develop diagnostic criteria, and even the name like ARFID or the name OCD, we're trying to describe a phenomenon. And I think we have to be careful not to get too tied into the box that sort of puts us in, and really try to understand the individual and what's driving that, because it's really going to inform treatment. So if somebody's having, a lot of really significant, sensory overload, right? I think it's really going to inform the process that we take, right? I think we always want a lot of collaboration with the individual, and sort of moving at their own pace with things. And I think another thing too, because I saw a couple comments in the chat, is, I think one thing we really have to consider is when we're thinking about ARFID, we're really thinking about that the person's really struggling to meet nutritional requirements. Their body's not getting everything that it needs. So there are certainly people who are more restrictive, or maybe quote unquote picky eaters, where by and large their body's getting what it needs. So okay, I don't like this, and this, but my body's getting everything that it needs. So that wouldn't necessarily lump somebody into like a pathological category or an ARFID category, right? We're really talking about this food avoidance is so extreme, that the person's body is not getting all the nutrients that it needs, or they're avoiding social situations because they're just terrified that they're going to have to eat this other food that other people are eating. So we're really talking about a level of clinically significant distress, or medical consequences from the behaviors.
I'm curious, do you have any tips for loved ones or caregivers who might be supporting a child or a loved one who has some of those food fears related to contamination or sensory issues?
I think to start off with, don't force kids to eat. I think a lot of times as a parent, it could be really anxiety provoking to see your kid not getting nutritionally like sound meals, let's say. But we got to remember there's a fear component in here somewhat. So we don't want to necessarily force them to have certain things, but to give them options, right? The idea, even in treatment, is to help people develop confidence in facing their fears. And in order to do so, sometimes we got to go really slow. We got to take different steps, right? Like little by little. Um, and if we can give them options, like as a caregiver, right, then they can feel a little more confident in, I was able to face this and I was able to, make steps in this direction. Um, you can ask them about willingness. Are you willing to try this out? Versus like, you must do this. Sometimes that can feel really intimidating, especially for like the little ones. Um, so sometimes kind of meeting a person where they're at, or even like pairing preferred foods with non-preferred foods can be really helpful. Because again, I think we're trying to help them develop a more peaceful relationship with food, right? Not one that's so based on fear. So if we can have a more calm environment when eating, a more positive reinforced, you made these great steps, you're very brave, you can do hard things, that can be really reinforcing, especially for the little ones.
And to piggyback off of that, something that can be very helpful is to one, validate the individual, how they're feeling. So, I can really sense or see that you're fearful of this, or you have anxiety, or you're nervous around eating this, to let them know that you get how they're feeling, and offering them, can you do this despite how you're feeling, right? Can you try this out? Can we experiment? Bringing some curiosity and fun into that space can be very helpful for people. So really offering, let's really get curious around this. Let's say it's like blueberries or pizza. Like, let's get curious around, like, what does it smell like? What does it look like? Does it remind you of anything? Just bringing that curiosity is very helpful when your brain is kind of stuck in a fear-based. It brings this whole other side to it. It's using a different portion of your brain to stay curious, and it opens your mind up to possibilities as opposed to closing off your mind that, oh, I can't do this. It brings that curiosity and increases someone's willingness as well.
I'm really glad you mentioned that, Katie, too, because I was thinking like oftentimes when I am working with someone and we are doing, like a food exposure or a meal exposure, where I have them bring a type of food that they're not typically comfortable with. I sometimes I don't even have them eat it in that first go. Sometimes it's just there, it's on their plate, and they have their preferred food with them. So it's this in their vicinity, and it helps kind of build that comfort to where, okay, I've seen that food before, it's been there, maybe next time I'm gonna touch it. And it is very much like I know a lot of people are, tell their kids not to play with their food. However, I do think it is an important thing to explore again, is like it is okay to play with your food if you're uncomfortable and to feel comfortable around it. So that I really thought of that.
Yeah, and I think Paige, I think you bring up a great point there, right? Which is when we're looking at the senses and sensory sensitivity and the senses and the aspects of food, we're really looking at all aspects, So sometimes our natural thing is like, oh, I don't like the way it tastes, right? But when we're really looking at things, it could be the sight of the food, it could be the smell of the food. It could be the feel of the food, right? So there's a lot of aspects to really navigate more than just, well, how does it taste? So depending upon how that is for the individual, we can sort of adapt things. And I think the other thing, just to kind of add in related to the question on like family support and stuff, I think is it's so critical for families to be involved in supporting their loved one and really learning this stuff really well too, so that they can kind of support the efforts at home, really taking an active role in therapy, versus sort of the drop off kind of therapy. If you just kind of drop your loved one off and it's like, okay, go do the work and I'll see you later, but really taking an active engagement in therapy and really learning. At CHI, we almost always involve the families. It's such a crucial component to reinforce the skills and the different approaches and perspectives. So it's a really key thing.
Yeah, and that's why here at Anna too, we're excited to partner with Feast to offer peer support groups for caregivers and for parents and for siblings as well, because we know that eating disorders can impact the entire family. So it's not one of those things where it's just the person with the condition that needs treatment or needs support. Oftentimes it's those loved ones too who can really benefit from talking with somebody else and taking care of their mental health. One of the questions that came in through the chat that got me thinking is what about food restriction or fear of foods when it comes to chronic illness? So somebody in the chat mentioned migraines. Another one that I hear oftentimes is ulcerative colitis or Crohn's. And that kind of leads to some of that fear around food. Where does that kind of factor into the whole ARFID OCD realm?
I can start first and take a stab at it. Again, I think it's looking at to how severe the individual's fear is, right? If it's like more on the line of like nervousness and they're fearful because they've experienced a different reaction or response when they eat certain things, and now they're being more mindful and aware around eating particular foods at particular times because they know how their body responds to it, because they either have an allergic reaction or I saw histamine intolerance come up in the chat, and they're being mindful and aware of it in that way. So they're being vigilant. However, when it starts to tip into the other end of the spectrum, hypervigilance, really avoiding social situations because someone else might have the food and they don't want it even next to them. So we're really just looking at where do they lie in that spectrum and then again, as Michael was saying, does it then start to affect does it compromise their overall well-being and health overall? Meaning, do they start to become medically compromised? Do they have nutritional deficiencies with these particular fears? And it's working with a therapist and other individuals to learn how can we help you to bring you more back to what I would call the middle ground or the gray area within that, where yes, you do either have a chronic condition where it might be best to either reduce your intake of certain foods or avoid them altogether if it's a true allergic reaction like anaphylactic or something, and then working with that and walking through the person with how can we navigate your life so you can experience all the things you want to experience and also take care of yourself in a very self-care and compassionate way.
Yeah, I can speak to perhaps something also that links OCD and ARFID along what Katie was mentioning is that we see a lot of black and white thinking, right? This is either safe always or never safe, right? or I have to do absolutely everything to make sure of this outcome, or I didn't do like enough ever, right? There's that gray area is not something that's really like accessible for people. And the challenge is that as human beings and experiences of life, we often are in many gray areas. But when there is anxiety and when there is a condition such as an eating disorder or OCD, it's almost like glitchy, as Michael mentioned earlier, right? It's like it feels like I have to have 100% certainty of something, otherwise I can't do it. And when it comes to taking care of our bodies, not everything is so extremely black and white. Um, and at times we might have good intentions and we might make a mistake. Like I'll share a quick story. So this morning I got my coffee with regular milk and I'm lactose intolerant. So um, had to get a different copy. But we try, right? And we're gonna have to sometimes figure out that we made a mistake and we can bounce back from that. And maybe we get a stomach ache or maybe we're, not feeling super great through the day. But when there is ARFID, when there is OCD, those situations feel so incredibly heightened that people feel they have to go above and beyond to make sure that absolutely doesn't happen. And OCD and ARFID don't let people see the flip side, where we can overcome those things, as challenging as they might be, as uncomfortable, distressing, is something we can still overcome. And that's where we want to help people see their courage in facing fears and being able to step into some of those gray areas.
Yeah. That's a really good point. And that's very personal for me too, because in my recovery, I was diagnosed with diabetes. So now here I am having to balance that chronic illness in addition to recovery, which requires a lot of conversation with my dietitian and with my therapist to make sure that the decisions I'm making are not coming from the OCD or from the eating disorder, that I'm listening to my body and listening to the hunger cues and making the decisions based upon my health and not necessarily based on the disorder. And it's difficult at times because there is this very black or white way of thinking. And one of the conversations that I always have with my therapist is, did you embrace the gray this week? And just being able to embrace that gray area and realize that it's not one extreme or the other, and that having a bite of this food that in my mind I might have deemed off limits is not going to be the end of the world. So it's definitely having to embrace the gray. That's a theme I live by these days.
Yeah,
Another question that came in around this topic is around pans pandas, and this is something that we had just talked about a little earlier in the month here at ANID. Could you maybe talk a little bit about how pans pandas might overlap with OCD and RFID?
I can speak to that a little bit. So for those that don't know, we'll see if I can remember these acronyms because I always mess it up. So PANDAS, pediatric autoimmune neuropsychiatric disorders associated with streptococcal virus, and PANS, uh, pediatric acute neuropsychiatric, I think. So the etiology of these is a little bit different. Whereas typically we see OCD sort of develop with more of what they would say sort of like a slow and insidious course where it's sort of growing over time. It's like when people look back, they'll say, "Oh, I sort of noticed this, when I was younger, I did this little thing or something like that." And over time, it's sort of growing, 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 growing. With PANS and PANDAS, typically the way families describe it is it's sort of like my child changed overnight. It's typically kind of like much more neurological in function, oftentimes, accompanied with like motor and verbal tics, Tourette's, like a sudden extreme exacerbation in obsessive compulsive behaviors. Um, I'm not aware of specific literature on a relationship between PANDAS and ARFID in particular. But what I could say is that, maybe if someone is already struggling with let's say fitting into that ARFID category, right? And then we have, someone, developing OCD symptoms from that route of a pans pandis, and we have that layering on top of, an already existing ARFID diagnosis, or if the person already has, OCD from that end, and then we're developing an ARFID side, or maybe perhaps the person's, also on the autism spectrum, and there's increased sensory sensitivities, right? Can just make things, even more complex. And it gets very difficult to kind of find out, okay, well, to what extent is it, maybe a wiring difference, with a sensory sensitivity versus how much of it is now the fear component on top of that. Um, and so with the PANS Pandas cases, we're really talking about working with an interdisciplinary team, similar to what we would do with, someone with OCD and an eating disorder, in general, where we do want a medical provider on the team who has a really good understanding of PANS Pandas and the treating the medical end of that. Along with working with a provider who's really trained and skilled in exposure and response prevention. Oftentimes we're including a psychiatrist on the team. If there's eating concerns, we're including a dietitian as well. So we're really trying to put together a team that can work and collaborate together to develop a treatment plan that's really going to help that individual. But it does make things more complex. But when you've got a team of people around you supporting you, I think it makes it, infinitely more manageable to navigate and get to good outcomes.
All right, so I kind of want to shift gears here a little bit into that seeking help and seeking support. We already kind of touched upon why ARFID is sometimes misdiagnosed or missed. But one of the questions that came in during the registration was, why don't doctors want to diagnose kids and adults with ARFID? I think that's just a really impactful question to ask. So I'd be curious to get your perspective on that.
Oh, do you want to start, Paige?
You go ahead. I'll piggyback off what you say. We're probably going to say the same thing.
So, I'm going to bring diet culture into the mix for a sec, because just overall eating disorders tend to fly under the radar because a lot of behaviors get seen as, hey, that's just something someone does, it's fine, like, ignored, when in reality, these are so problematic. As we mentioned also at the beginning, I think ARFID is also a diagnosis that has only been recognized, I believe, since like 2014, which I know now it's like a decade, but it's still pretty fresh for a lot of people. Um, with that in mind, I think it's also been misconstrued as a disorder of childhood. And what we know is that more and more folks are, being noted as having ARFID later in life. Adults definitely can have ARFID. And as Paige was mentioning, like kids, it could just be seen as like that picky eating, like, oh, we don't need to put a label on this, they'll grow out of it. They're just peculiar in that way. It's so much easier to kind of dismiss, um, which makes it really challenging to recognize and diagnose for what it actually is and the impact that it could have on someone's like life, which I think across the board, eating disorders, they, tend to be minimized in that way, which I think already makes it so much more difficult to even get ARFID into the right space to be like diagnosed.
I was definitely thinking diet culture as well plays like you said, a large role in that. And then on top of that too, just I don't like to use the word lack of education because obviously providers, they have a ton of education, they have a ton of knowledge, but I would say like lack of understanding in the world of eating disorders because they are so, I mean, for example, as a dietitian, going through school to become a dietitian, I think I got a slide on anorexia nervosa and bulimia nervosa. And that was literally what they taught me about eating disorders as I was becoming a dietitian. And I just think it's something that all healthcare providers do come across but they don't realize it because it's not being taught in our schools. It's not being educated. It is very much, they kind of just let it go under the radar, because I do think diet culture does play a role of a lot of the behaviors in an eating disorder, such as, restricting is deemed as, well, you're dieting and you're trying to watch your figure, so A-okay by me. So it's definitely something that I struggle with and would love to change and have so many goals to change in the future so that more healthcare providers do understand what it looks like and know how to um, address it and refer to specialized providers.
If I could add to that, I will say, I think lack of education is a huge issue. Among, psychologists and therapists in general. You ask them how much, training they've gotten in the treatment of eating disorders or even the treatment of OCD. A lot of therapists think, well, oh, I treat anxiety, I can treat OCD. OCD actually takes a lot of skill and training to treat. Eating disorders take a lot of skill and training to treat. And among, as Paige said, dietitians and physicians as well. I spoke with a physician recently and just asked them sort of like out of curiosity, how much training do you guys get specifically related to eating disorders, during the course of medical school, if you're not specifically seeking things out? And I think they shared it was like 1 hour of one class during one semester. So I think there is a huge education gap. I mean, you can sort of just ask yourself, when was the last time your physician checked in with you and asked you, how are you feeling your body? What did you eat today? And getting like that kind of an understanding of things versus just looking at the weight on a scale and saying, oh, that looks good, or that looks too high, or that looks too low, without really asking and understanding. And the same thing for many therapists as well. When is the last time, a therapist checked in with you, unless you're working with a specialist, of course, and asked you, what are you eating in a day? What's eating like for you? What's an average day of eating? Have you struggled, with any disordered eating behaviors in the past? And these questions, on average, I think we could pretty confidently say are not being asked. So there is a huge education component, and it's been challenging. It's really been challenging to break through on that end.
Yeah, and that ties into another question that somebody did ask. I know we've got a couple providers who are joining us today. Where can they go for that training? Where can people go for that type of education?
I'm going to plug here real quick, IOCDF. Definitely wonderful when it comes to OCD realm of things. And then on the flip side of that, IADP, which is the International Association for Eating Disorder Professionals. There's local chapters that, do trainings and presentations. There's also the national conference where, we're getting more traction also to speak up about ARFID. So these are kind of like your main, I think, hubs of training. I would certainly check with like locally if there are any chapters that you can join and kind of connect with. If there are any specialists, gosh, in your area that you can consult with and can kind of like help you look for the right trajectory of training. I think that's kind of like your best avenue. And then also treatment centers at times offer like free CE workshops online, trainings. Um, and of course, the National Alliance for Eating Disorders is huge when it comes to training. They have a training day coming up next Friday, I believe. No, in 2 Fridays. And these are low cost trainings accessible to people. So just looking out for some of these organizations, I think it's a great place to start.
Great.
Yeah,
Thanks.
and there's
Yeah,
sort of
for
more and
sharing.
more out there, every day. Lisette, Katie, and I all sit on the leadership board of OCD Eating Disorder Special Interest Group through the International OCD Foundation. Where we, help support both clinicians and community members. So, for people who are interested in it, through avenues like this, through ANAD and other things, we're really trying to bring up awareness and start to put, more education awareness, into place. But there is a lot out there, as Lisette said, in terms of getting involved with local chapters. We see a lot of stuff out there. And I think, we get a lot more calls now where either the individual seeking treatment or the family member seeking treatment is actually pretty aware of ARFID. It's actually, I think we've seen a big uptick in that. So something is penetrating, and with all the people joining today too, seeing that and wanting to join and learn more about it, I think that information is kind of pushing through, which is something that's been really cool to see.
Yeah. All right. Well, another question that came in, and I know it is not this easy. It's almost going back to that gray area again that I was talking about. But somebody comes to you with both OCD and ARFID. Is there one that you treat first? How do you put together a treatment plan? How do you do that initial assessment to really determine what the next steps are going to be?
I really gotta say I appreciate this question because I think this is a question that comes up a lot for us too. Like, where do we start, right? And I think the important thing that I want people to remember and consider is medical stability. I think we got to start with assessing where the person is at medically to help us tailor treatment accordingly. A lot of times, if someone's coming to treatment in a malnourished state, we're not really going to get a lot of headway with psychological care. And honestly, like, that's going to have to take priority. However, at the same time, when there's a fear involved and you have to face some fears in treatment, in order for the person to be able to eat, to then be able to be nutritionally stable, we got to tackle it from that side. So it really has to be kind of like a joint effort on being able to tackle both, but making sure someone is medically stable to begin with.
And this is
And
where just
go ahead,
sorry,
Kate.
Michael. I was going to say, just to piggyback off of what Lizette said, this is where a multidisciplinary team is so helpful for the individual. So bringing together, psychologist or therapist who specializes in that comorbidity, a dietitian who also understands that, a psychiatrist for that piece, medical doctor. There might be a few others I'm not thinking of, but that is really important for the individual's recovery.
Yeah, and I think, what I try to tell patients as well is right, the treatment is not really dissimilar, right? These things kind of come together, right? And what we're learning about is what can we teach our brain today, right? The brain sort of sorts between this is safe and this is dangerous, right? If there's let's say if we're concerned about the adverse consequences of a food, right? Or someone's worried about what if I choke on this food, right? Or something like that. So they've avoided that food. And now their brain has learned, oh my God, if I even see that food, my brain is just on fire and I'm in panic because I'm worried, I'm going to have to eat it and something awful is going to happen. Right. Not dissimilar from if we're working with someone on, an OCD contamination fear, right? And they're worried about, okay, if I touch that doorknob, I'm gonna get germs on my hands and I'm gonna get sick. And so, you know what? I'm just not gonna touch that doorknob because I really don't like that doorknob. So the brain is on red alert when it sees that and when we're in that situation. So we're really trying to think about, are we showing our brain messages of this is dangerous or this is safe, right? And can we approach that in a systematic way that helps the person get their life back? So the nice thing about the treatment, and obviously there's complexities and there's exceptions and it's individualized, is that we're not sending two different messages, about what to do, right? It's about confronting things that are hard and challenging and building distress tolerance for things. So the treatments are are very aligned. So that's the positive thing. And of course we're, always looking at medical stability first.
Now, I know everybody should come to you for support because you all provide tremendous treatment and support. But what kind of questions should patients or loved ones ask to advocate for themselves when looking for that right provider?
Really the first thing that came to my mind, and it's more of like just if you are struggling with an eating disorder or disordered eating in general, a tip that I do often recommend patients and loved ones is, again, we do live in a very diet cultured society. So I often recommend, like, if you are working with a provider that states that they specialize in eating disorders, but then a couple rows down, you see they specialize in weight management or weight loss. Those do not go together. And I often recommend that they will find someone who doesn't have that as a specialty, because that is still just very stuck in that diet culture. So that's really the first thing that I recommend when talking to someone.
Big red flag. Yeah.
Yeah, another question that came in, and this is kind of a twofold question. So the first part of it is navigating some of life's milestones with ARFID and OCD. Things can feel like they're going good, and then all of a sudden, there's graduation and you're off to college, or something happens in the family and there's a change there. How do you navigate those life transitions, those life milestones? And also, for those of us who might be in recovery from an eating disorder, how do you manage the times when OCD rears its ugly head and it pops up and you've got to manage OCD while still being in eating disorder recovery?
What I often say to folks is, especially for OCD, life transitions are a time where OCD does tend to flare up. So when I'm working with my patients, we always try to kind of anticipate that ahead of time. Obviously that's not always possible, but when we know a life transition is coming up, maybe a little bit more on guard and understanding that things might be a little bit more difficult, right? Because I think when things feel a little bit more out of control, we're going through a transition and a lot of change, we cling to some of the things that feel safe, right? So with an eating disorder, maybe the foods that make me feel safe. When it's OCD, maybe we see a little bit of an exacerbation of compulsions, or we see a little bit more avoidance than we typically would. So I think with that, a lot of it is, working with your individual provider on, I know we didn't get too much into exposure and response prevention today, but that's our gold standard of treatment for OCD. And that's being used for ARFID a lot in large part. The evidence base is still, I think, growing and growing and growing around ARFID treatments, but really having a mindset of approaching the things that feel scary, so that in the long run I can teach my brain that these things are maybe safer, or they're things that I can tolerate, versus that temptation to kind of go back to the compulsions and the avoidance. And I would say the second hand is a lot of self-compassion, a lot of kindness. I think we almost always integrate self-compassion with this work, because it's not about perfection. And I think it's very much about giving yourself kindness and then thinking about, okay, how do we get back on track? Rather than just beating yourself up about having a rough day, a rough week, a rough month. But it's about applying that kindness and then coming up with a good plan to get back to where you want to be.
And I wanted to piggyback off of that too, of the, that self-compassion and having that kindness for you, for yourself, is even say you are in recovery from your eating disorder and something does happen, it is okay, right? That is life, unfortunately. And it's important to also reach out for support, reach out to friends and family of loved ones who are great support systems for you. Reach out to, maybe you haven't met with your dietitian or your therapist in a couple months. that's okay. It is okay to always ask for help when something comes up. You do not have to be this cured, perfect human being. There's no such thing. So it is okay to still rely on our support systems that we had maybe when we were struggling more. There's nothing wrong.
And I love the fact that you brought like the humanness to the mix page, because I think I saw this question earlier through the chat about does OCD get cured completely, right? And I think it's a question that we get asked a lot, and I think with eating disorders it's just the same way. Like we do believe that recovery is possible, and there is such a thing as recovery. And at the end of the day, we're still human beings, and human beings we are a sack of meat and electricity and anxiety, and we're gonna come back to having anxious moments. Like that's part of who we are. So, with bringing on a self-compassionate stance to the fact that we will have moments of anxiety, we will have fears. It's not the exception that that's going to be something that happens, that it doesn't mean that your recovery is damaged because you engaged in behaviors, right? It doesn't mean that, oh my God, OCD is in full force because I gave into some compulsions here. We're still human beings, and recovery recognizes that anyways.
Sorry about that. I was muted. As you were sharing your coffee with milk incident earlier today, that got me thinking too, just about how, yeah, especially at the beginning, I was like such a perfectionist around recovery, and even the slightest slip or hip cup along the way, and I thought, "Yeah, I have to start all the way back at the beginning again." But one of the things that was reinstilled in me through my support team was that nobody can take away the progress I've already made. No, not one event, not one meal, nothing has the power to take away the progress I've made since I started this journey. So that was an important reminder that I had to keep up, especially through those challenging times that have happened, and I know will happen in the future too. So yeah, thank you for sharing that. Let's see, we've got a few more minutes left here. Another question that did come in is how does EDS interact with ARFID and OCD? I was curious if you could maybe speak a little bit more about that.
Right? Isn't you're speaking to like eating disorders, EDS?
Oh, Elder Dolls, how do you
Oh,
say? Yeah, I can never pronounce it correctly, but yeah.
anybody want to chime in?
So the question is, how
Yeah,
do
is
they
there like an
intersect?
interaction there between ARFID and OCD?
So I know some things about EDS, Ehlers-Danlos syndrome. I think it depends what type you have. So if you also have MCAS along with it, or POTS along with the EDS, which many times it comes in a trifecta, that many people who have EDS also have either POTS and or MCAS, which is mast cell activation, which they have symptoms in and of themselves. I'm just curious if that's what they're more referring to with the ARFID component. Also, for some people with EDS, there's certain foods that can trigger those things, such as high histamine foods for some people. For other people, that does not make a difference. For some people, again, depending upon what type of EDS they have, I believe there's 13 different types of EDS that it's looking at foods that are more anti-inflammatory just to help out with symptoms and pain that can accompany EDS. So I think it's much more involved than just a simple, it's really looking at the person, what symptoms they have, and then helping the person to navigate that. So again, we're staying in the gray area as opposed to dipping into too much fear around food in certain circumstances, and really working with providers around that.
That is one common theme that from this conversation and pretty much every conversation that we have around these topics is that there is a big gray area and that it's different for every individual person, which is why I think it's so important that there's never like a copy and paste treatment plan or anything like that. Like treatment needs to be individualized. Recovery is an individualized process. What recovery looks like for one person might look different for another person. So it's being able to remember the human element and the individual aspects of everything. So before we wrap up today, I'm curious, panelists, do you have any closing thoughts? Anything else you'd like to share around ARFID and OCD today?
I'm going to just reiterate recovery is possible. And just even in taking steps and being like part of our conversation today and connecting here if you're making steps forward. I think a lot of times it can feel really debilitating and really isolating to go through some of these experiences. But I really want to encourage people to speak up. We're really trying to break the stigma, bring awareness, right? And connections come out of vulnerability, right? So oftentimes you may not know what someone else is going through until you share your vulnerability with them. There's people out there who want to listen. There's people out there who want to support. So you're not alone, and continue to move forward. There's people here to support.
Yeah, and I think I just want to add encouragement that more and more research is being done every day. More and more clinicians, are aware of the comorbidity of the overlap. There's more and more conversations like this happening more frequently. So it's really a great time in that sense because I think people felt misunderstood and not heard for a long time. People would be pushed into different boxes that they're like, hey, I don't fit in this, right? And that's the problem sometimes with these boxes. So I think I'm seeing a lot of growth within the community, a lot more effort to listen and understand, a lot more research occurring, a lot more bringing in and integrating folks with lived experience to share their stories and their conversations. So these are all really encouraging things, and I just want to thank everybody who joined us today. And I think just encourage you to give yourself a lot of credit for, partaking in this, watching, sharing, asking questions and stuff. That in and of itself, I think is a really big deal.
Yes, thank you to everybody for making this conversation possible, for all the panelists who joined today, for all the attendees who have submitted questions or have listened. I will share the recording out after this. I'll include some resources on there as well. Just wanted to mention too that there's the ANID treatment directory on our website. We also have a referral program, so if anybody needs help looking for a provider in their area, definitely feel free to reach out to us there. Also, another thing that we're hoping to include very soon here is an ARFID support group moving forward, but we need volunteers. So if you have lived experience and you're at a place in your recovery where you're ready to start supporting others, definitely feel free to reach out because we would love to get that group up and running as quickly as possible because we know there is such a need. So with that, we'll go ahead and close out the conversation today. Thank you all for joining us, and I hope you have a wonderful rest of your week. Take care, everyone.
Thank
Thank you
you.
so much. Have a great one, everyone.
Bye.